This program is brought to you by Emory University.
Welcome to Cardiovascular Grand Rounds. This morning we have Dr. Ravi Rajani with us today. Ravi's, as you know, a vascular surgeon who's a large interest in trauma and vascular surgery. He went to medical school in Michigan, did his training between Emory and Cleveland, sort of back and forth a little bit. We're able to keep him here as you know, as part of a package deal that we help secure a faculty appointment here in cardiology. His wife, Divya, as you know, is in one of our advanced heart failure and transplant physicians. Ravi is based largely at Grady, where he works very closely with the cardiology group there, and again is interested in vascular trauma. As you can see from the introductory slide, he actually has a secondary appointment in the Department of Medicine in the Division of Cardiology. So we welcome him as one of our own here for talk about contemporary management of peripheral artery disease. Ravi.
Good morning. Thank you for the great introduction, Dr. Taylor. Thanks for having me today. My voice is on the fritz a little, and no one told me this was going to be videotaped, so if I walk away from the camera, just remind me. I enjoy looking at my nose, those of you online. Don't necessarily mean for this to be a one-way street. Certainly feel free to interrupt if there's any questions, particularly among the trainees. I'm not going to go into a lot of the basic definitions or terminology. We'll touch on some of it, but for the most part, we're going to be primarily data-driven. And I suspect it will not take the whole hour, so please feel free to interrupt. So obviously talking about peripheral artery disease, I don't need to tell you guys that this is a major problem. I suspect that 6% truly underestimates things. I mean, it is over the age of 40, which for many of us is right around the corner. And that's probably 6% of people over the age of 40 have some element of even asymptomatic disease, and is just found on routine screening. Probably about 7 million symptomatic individuals in the United States. It's obviously got a large healthcare burden. Everyone here understands that it is a significant risk factor for systemic atherosclerotic disease and is essentially a major coronary artery equivalent. It's getting an increasing amount of press as well. I think we see more and more advertisements and sort of health messages for PAD than we've seen probably 20 years ago. I think there's a lot of interest financially. The risk factors are the risk factors for standard atherosclerosis. I think that we all know that male gender is probably a big one, but quite honestly, one of the big things that we're seeing, and you all are as well, is an underappreciation of how much burden of disease there is in females. And certainly there's an increasing interest in how PAD treatment differs among women and compared to among men. Many of you are laughing. Please do not take this slide as an admonishment that we should be out drinking and getting wasted every single night of the week. But yes, in large population-based series, heavy alcohol use has been found to be significantly protective because probably a lot of those patients die before they get systemic atherosclerotic disease. It truly is, this is the standard the United States population is aging slide. It truly is something that we're seeing more and more of because people are getting older and older, and the incidence and prevalence does increase up through every single decade generation, right? So at the age of 80, you are substantially higher at risk for PAD than you are younger, but we're seeing it more and more in 40-year-olds. And quite honestly, we're seeing it a little bit more and more in 30-year-olds who have obviously some underlying genetic predisposition to atherosclerotic burden, but it's not that uncommon. I think it's still not quite as common as we see a early age MI, the 30-year-olds that you guys see who come in for whatever reason, hypertriglyceridemia, hypercholesterolemia, have some significant early life event. It's not as common as a stroke in a young person, but we're starting to see more and more lower extremity burden of disease in particularly young people. If you think back to medical school, we kind of did you a disservice. I really want to walk around right about now. We kind of did you a disservice. And we mistakenly teach people that it exists on a continuum of disease where you claudicate for a while and then it gets worse and then you get rest pain and then it gets worse and then you have an ulcer on your foot. When in reality, it's not quite that simple. I think the easiest way to think about it is it's actually two different disease processes, right? So there's the claudicants and then there's the critical limb ischemia. CLI. Critical limb ischemia is a term that we use to encompass anyone who has either ischemic rest pain of their foot or ulceration or gangrene, some sort of tissue loss of their foot. And in reality, they're very, very different diseases. there's a very small amount of crossover, to be quite honest. Very few patients who have critical limb ischemia actually have an antecedent history of claudication. Very few patients who show up with an ulcer on their foot actually have an antecedent history of claudication because the disease burdens affect different levels, right? So when I think about somebody who falls into that critical limb ischemia side, I often think of someone who maybe on the younger side, maybe has significantly advanced diabetes, maybe has significantly advanced end-stage renal disease, and has disease that's isolated in many cases to just the below-knee vessels, which makes it so that they can't heal a neuropathic ulcer, which is often the inciting event of tissue loss. When I think about someone in the claudicant camp, it's often someone who's had long-standing history of smoking, oftentimes older, oftentimes affluent, to be quite honest, and gets this sort of lifestyle limitation because they can't walk as far. Again, there's some crossover. I don't mean to say there isn't, but it's helpful in my mind to think of it as two different disease processes. And part of the reason I think that's helpful is because the outcomes really need to be assessed differently. So for the claudicant, we're not talking about a 10-year risk of losing your leg. The natural history of claudication, as we'll talk about in a few minutes, is not limb loss. It's continued claudication, quite honestly. It's rarely progression to rest pain or tissue loss, although those things can happen. When we're talking about someone with critical limb ischemia, we're really talking about limb salvage, right? So we're talking about trying to keep a leg that is going to go away unless we intervene. It's also about reducing that infectious burden, which has significant financial ramifications, as you can imagine. That's not to say that the overarching theme here is that the major intervention is primarily done on a risk factor modification side, right? So we're talking about significant atherosclerotic burden. No one dies of claudication. No one dies of claudication. Really, very, very, very few people die of the septic implications of having a dead foot, to be quite honest. That's an extremely rare cause of death in this patient population. Everyone that we're talking about dies of a heart attack or dies of a stroke, right? They die of their systemic atherosclerotic burden. And while it's important for me to think about how we can make their leg better, how we can save their leg, I'd be remiss if we weren't paying better attention to how we've handled their overall risk factor modification. So with that in mind, keeping in mind those two different types of outcomes, I really want to focus on three major contemporary changes, right? Three changes in sort of how we've thought about these patients, how we've treated these patients over the last 20, 30 years. The first I would say is probably most important is advances in medical therapy. There's a lot of different medications that we use for risk factor modification. I'm going to focus primarily on medications that have been proposed that would improve angiogenesis and improve the ability of these patients to walk and to save their leg. And then next I want to talk about where our threshold is for revascularization. If you ask any vascular surgeon who was trained before, let's say 1980 generously, do you intervene on claudicants who are continuing to smoke? The answer to both of those points would be no. We do not intervene on patients who are claudicants, and we do not intervene on patients who continue to smoke. That's very different than the reality we have now in the year 2015. That's very different. There's been a generational change about our threshold for offering revascularization. And then thirdly, obviously, talking about some of the interventional device improvements. That'll be some of the data-driven portion of this and less of the theory component. Starting with these advances in medical therapy. Everyone sort of has known the historical treatments of PAD. Again, the goal is twofold. One is to improve the leg, and the other is to reduce their cardiovascular risk. But many of the therapies overlap in both arms. As you can imagine, both antiplatelet therapy, whether it's aspirin or Plavix, really has been shown to be helpful in terms of what someone's pain-free walking distance is, and obviously secondary prevention of heart attack or stroke. We know that a graded exercise program helps how far you can walk. That's been shown in multiple prospective randomized trials. Probably helps reduce your cardiovascular risk, but obviously a harder thing to show. Smoking cessation is the cornerstone of therapy. We just happen to be really terrible at it, right? So one of the things that we've looked at Grady is looking at a disadvantaged patient population and how well do we meet risk factor modifications goals in a disadvantaged population. It turns out for aspirin use, statin use, blood pressure control, A1C control, we actually do pretty well when you compare the insured versus uninsured groups. The part where the uninsured folks really run into trouble is the smoking cessation. And that's regardless of whether they have the same access to a multidisciplinary program, same access to pharmacologic adjuncts. They just really struggle with smoking cessation for probably financial reasons. I'm not going to talk much about cilostazol. Who here has everyone has some familiarity with cilostazol, I assume. You guys have heard about it before. True or false? Show of hands. Cilostazol has been shown in randomized controlled trials to improve patients' pain-free walking distance compared to placebos. Who thinks it's true? Who thinks it's false? Yeah, so in probably 3 randomized trials, there was a statistically significant increase in pain-free walking distance with cilostazol, but I don't give it to patients, quite honestly. If you look at the placebo group in those trials, it was a 1-block pain-free walking distance. The cilostazol group, 1.5 blocks. It's a half a city block, right? So for most patients, it's not going to be an appreciable difference where it's really worth the potential side effect profiles and is obviously relatively contraindicated in underlying heart failure. What I really want to spend some time, not a whole lot, because I'm certainly not the one to talk to you about, and you have people in your own division who are true leaders in this field, but the idea of gene and cell therapy for PAD, right? So can we induce angiogenesis to the point that we can actually make new blood vessels and allow folks to walk around? How many people here have worked in Dr. Kayumi's lab? I thought all you guys worked in Dr. Kayumi's lab. Well, obviously, GM-CSF has been a big part of his research for a long time, both in the coronary beds and the peripheral beds. But other groups, every major academic center in America has some trial that's been going on for at least the last 5 years about injecting something into someone to build new blood vessels. And what are we talking about? We're talking about angiographic changes that allow someone to go from a picture that looks like this, where you see very few native vessels, significant collateralization, to where you're starting to see new collateralization to the distal beds. And there's been sort of mixed results, obviously. For the most part, this is a 2013 summary of some of the gene and cell therapy trials which are out there. For the most part, the objective evidence shows us that the ankle brachial index in many cases actually improved. And that's great, right? That's a fantastic finding that's sort of leading us on this step to a holy grail treatment, medical treatment for true PAD. For the most part, limb salvage has really improved as well. We've shown in multiple trials that, in clinical trials, that the chance of limb salvage actually improves. But we really don't have a go-to agent. We really don't have a go-to protocol. It's not at all in widespread use, and really it's isolated to true prospective clinical trials. We don't have great placebo-controlled randomized control trials yet on a large scale that would allow us to go ahead and get FDA approval for some sort of angiogenesis type medication. That just hasn't happened yet. Really, the efficiency of therapy is an issue and the consistency of therapy is an issue. We have patients who are great responders, and then there's patients who really have no response whatsoever. That's all I really want to talk about for medical therapy. Realize my primary appointment is in vascular surgery, so we're going to primarily be talking about the interventional side of things. But the key thing in terms of medical therapy is, where do we stand with gene and cell therapy? Is there going to be something within the next 5-10 years that will be used on a consistent, large-scale basis to promote angiogenesis? The other thing that we've seen happen, as I mentioned, over the last 20 years is changing who do we offer revascularization to. So historically, everyone with critical limb ischemia would be at least considered for revascularization. As we mentioned earlier, that's truly a limb salvage question. If you ask my boss, Dr. Dodson, when he came out of training, do you intervene on claudicants? The answer for the most part would be no, to be quite honest. And it would really be minimized to patients who demonstrated true failure of optimal medical therapy. And for most people, that includes legitimate, durable smoking cessation, which we all know is a very hard thing for these patients to accomplish, or if they had some significant lifestyle limitation. I think you have to be careful about how you define that, right? So I don't define that as number of blocks somebody can walk. I define that exactly how it means. So we have little old ladies who come in and they're 80 years old and they can't walk from here to there without their legs hurting. They don't have rest pain, but they can't walk very far at all. But you ask them, does that impact your life? Is there stuff that you want to do that you can't do? And the answer is no, quite honestly. I don't really have anywhere to go. I don't have anything to do. You see a 45-year-old male smoker who used to golf 18 holes a day, can only golf 9 holes a day now. That's a severe limitation on his lifestyle. He can't get work, he can't do things, but he can still walk a mile or at least several blocks. The absolute distance that someone can walk, I think, is less important than what the subjective quality of life impact is. And that's a little bit different than it was 20 years ago. And the reason it's different is probably in part because of work like this. This was a seminal paper from 1996, and a lot has changed since then. But if you look at everyone over the age of 55, we say probably about 5% of those people have some element of claudication, whether they're identified or not. If you follow their limb outcomes, and this is over 5 years, it's extremely, extremely rare for those patients to progress to limb loss. 4% or so. 4%. It is not the standard natural history of the disease for claudication to progress to limb loss. Claudication leads to more claudication, and that's pretty much it when it comes to the leg. Most patients were not undergoing lower extremity revascularization. 7%. This was before the endo era. We say the endovascular era started probably about 1996 or so. So only about 7% of patients were actually undergoing lower extremity revascularization for claudication over a 5-year period. More importantly, if you look at their 5-year mortality, it's 30%. The vast majority of those, three-quarters, are due to either a stroke or heart attack, highlighting that for the most part, the historical treatment has been, for a claudicant, the most important thing we can do is make sure their risk factor modification is as optimized as possible. The leg is not necessarily something to worry about. Most patients will continue to smoke. Most patients will not be candidates for lower extremity revascularization, but that's okay. They're not going to lose their leg. In keeping with sort of this generational change that we've seen, nothing up here represents anything to do with quality of life, right? This is all defined outcome data for do you live, do you not, do you keep your leg, do you not. We don't care about their quality of life. Well, we sort of became nicer and we sort of had new tools available to us. And if you look at the start of the endovascular era in 1996, you can see that we saw obviously an increase in endovascular cases, particularly around the early 2000s. I'm going to magnify this up a little bit. And what we're really looking at now in the early 2000s is this is the line demonstrating how many endovascular interventions we're doing for lower extremity disease. This is the number of bypasses we're doing. So we've transitioned out from using bypasses to using percutaneous therapy. Okay. Well, the great outcome measure we have is that we have fewer amputations. We're not losing legs anymore. People are great. They're doing fantastic. They're not losing their legs. To summarize, we saw about a doubling of total number of cases. So about twice as many people who were getting lower extremity revascularization got it over a 10-year period. The main thing was a threefold increase in the number of endovascular procedures that were being done with about halving of the number of bypass operations. But like I said, it's great, 30% decrease in amputation rate. Except that if you remember, limb loss is not an acceptable outcome measure for claudication because if you just left the claudication alone, only 4% were going to lose their limb. So really what was happening is we were taking this orange line, which was the number of claudicants who were getting treated, and we really moved that to the forefront. If you look before, the majority of cases prior to 1996 were being done for threatened limbs. They were being done for rest pain, tissue loss, or this amorphous term called threatened limb. Nowadays, and this is 2007, and that we've seen a further increase, the majority of interventions are being done for claudication. So if you think about that, the lower amputation rates are hardly a take-home message that you can say we're doing a better job at taking care of patients. If you look at the patients who undergo revascularization for claudication, angioplasty bypass graft, that's infraluminal bypass graft, and this is aortobifemoral bypass, it's very, very rare that a claudicant ends up with an amputation. I don't remember how many years out this is, but certainly in the periprocedural period, extremely rare for a claudicant to lose their leg, reasonably rare for someone with a threatened limb as well. This push for how we rethought about how we treat claudicants, it's really easy for my societies to sort of get a hold of the now high horse attitude and say this is being driven by community cardiologists, community interventional radiologists. In reality, we've pushed this, right? So if you look at who's doing these procedures since 1996, this is the slide everyone's going to remember. Who's doing these procedures has really changed, right? This is sort of a redistribution in terms of who the practitioners involved with these patients' care are. In 1996, the vast majority of these procedures were done by interventional radiologists. It was extremely rare for a vascular surgeon to do angiographic work or endovascular work. Cardiologists have become more and more involved in the space, but really, and again, this is 2006, and we've seen an even further expansion of this exact same concept, where vascular surgeons are the ones who are pushing it. And the vast majority of complex lower extremity revascularizations percutaneously are being done by vascular surgeons. There's two ways to think about it, right? So one is that we recognized that other groups were pushing percutaneous revascularization, and to survive, we had to get involved in the field. And the other way to think about it is that as we got involved in the field, we probably pushed more aggressively than other folks because ultimately we were the bailout, right? So we were calling ourselves to bail out after you did one of those operations that you said, what the hell were you thinking? This is not a stent graft candidate, right? I think it's probably a little bit of both. I think that certainly the changes from 2006 to now have shown a steady presence in the field of both cardiology and vascular surgery, with an even further decrease in the number of these cases that are generally done by interventional radiologists. I would say in most academic centers that number has really, really dramatically changed. But in the community, there are certainly a lot of interventional radiologists who do these types of procedures. I think the big reason that we've seen an increase in the number of procedures we're doing is we've changed how we thought about claudication, right? And we moved purely from a limb salvage concern to a quality of life concern. And it makes sense. So in reality, we should have the same level of threshold for intervening on someone, whether we think we're going to do it endovascularly or open, right? If I think I'm going to angioplasty an SFA or do a fem-pop bypass, I should be able to say my decision should be based on patient factors. It really should have nothing to do with whether I think one is going to be successful and one isn't. But that's not the reality. I'm much more willing to put a patient through an angioplasty than I am to put a big incision on their leg. More importantly, the patient is much more interested in having an angioplasty than they are in having a big incision on their leg. We've also changed how we thought about continued smokers. So a big part of this really was the Buerger's patients. As those of you who don't know, Buerger's is obviously a small vessel vasculitis that is driven exclusively by smoking and can be very debilitating. But some work came out, and it's not great work, but some work came out suggesting that the genetic predisposition to smoking also tends to carry with it a genetic predisposition to Buerger's. So we thought we started to change how we thought about addiction to tobacco, right? That there's clearly a genetic component that some folks are just more prone to wanting to continue smoking. And because of that, many people in my generation sort of give smokers a pass, where senior surgeons will not. Many senior surgeons will absolutely positively not intervene on smokers. I'm going to come back to this later because we have some data saying that maybe we're not doing the right thing, that maybe our ancestors knew better than we did in terms of our outcomes. We've seen this across all the specialties, right? And then the other question is, if you take someone who has a serious smoking problem and you put them through some sort of lower extremity revascularization, does that put the fear of God in them? Does it lead to an increased chance of smoking cessation after their revascularization? And is that increased chance related to how invasive or how extensive their revascularization is, right? So are you more likely to quit smoking if you go in for a lower extremity angioplasty and touch up every 6 months, every 2 years, or to have one big operation like an aortobifemoral bypass that makes you see the light and say, I'm done smoking, I'm never going to do this again? No one's really looked at it that in depth. I will tell you that the small amount of literature, including from PCI versus Cabbage data, suggests that it probably doesn't matter, and correct me if I'm wrong in your field, but in our field it probably doesn't matter, but certainly something to think about in terms of evaluating a smoker for intervention. The thing I want to spend the most time on, though, is talking about medical device improvements, because obviously that's something that's got a lot of cross-fertility between both cardiology, specifically interventional cardiology, and interventional lower extremity disease. If you, this is the only terminology slides that I'll put on here. If you think about vascular surgery, it's pretty straightforward. There's only 4 things that we do to blood vessels, to be quite honest. We do endarterectomy, which means that we take out a focal area of plaque. The most commonly endarterectomized vessel in the world, obviously, is the carotid artery, but other vessels can be endarterectomized as well, like the common femoral. This is used for short focal areas of plaque. We get rid of it, and we oftentimes close it with a patch. When it's longer, we do a bypass around it, obviously the most commonly done bypass in the world. perfect timing, Dr. Guyton, is a coronary artery bypass graft, but certainly a reasonably distant second is lower extremity bypass grafting like a FemPop. If there's clot, and this is for clot, not for plaque, for clot we take it out with these balloons that we call Fogarty balloons. And if the vessel is bleeding, this represents the ligation of a branch vessel that a laparoscopic surgeon got into, and we have a lot of different ways of stopping bleeding like that. All of the core basic open operations have endovascular counterparts, right? So for the most part, if someone has a short segment of significant plaque, we have historically treated that with angioplasty alone, but in reality, the better representation is atherectomy, which many of you are familiar with. Atherectomy is designed to remove a short segment of plaque burden to allow an angioplasty balloon to work a little bit better. When the occlusion is maybe a little longer, then we start talking about intravascular stenting, obviously. We have percutaneous thrombectomy devices like the angiojet device represented here. This is an area of significant increasing interest, obviously with things like angiovac, the Penumbra device, a lot of other different aspiration thrombectomy devices. And then instead of ligation, we embolize. For the most part, it's gotten to the point that everything that we can do open, we can translate to the most part to some sort of endovascular representative. However, historically, what we've done has generally depended on which vascular bed we've talked about. I only want to talk about two of the three main vascular beds of the leg, the aortoiliac and the femoropopliteal. We're not going to talk a lot about tibial disease because for the most part, we're not sure what to do with interventions for tibial disease. When you look at the large vessels of the leg, the aorta, the common iliac vessels, this is where we have the biggest tradition of endovascular treatment. We have the biggest knowledge base. We have the most data. For the most part, iliac stenting works really well. There's really good long-term patency rates. It's probably preferable here because for the most part, it's much less invasive than the open counterpart, aortobifemoral bypass grafting, femoral bypass grafting, or axillofemoral bypass grafting. However, even within a pretty straightforward vessel, how to stent the iliac, there's two questions that we still haven't entirely figured out the answer to. Is it better to do POBA alone, angioplasty alone, or is primary stenting of the iliac always indicated? Should we use covered or uncovered stents? Should we use bare metal stents, or should we use stents that have a plastic or PTFE covering on them to allow exclusion of the thrombus? In reference to the first question, most of the data really comes from sort of the 90s to 2000s. There was a large randomized trial that the Dutch put on showing no superiority of stenting, but honestly, most people don't listen to that. This is the only randomized trial we have looking at primary angioplasty versus primary stenting of the iliac segment, and it conclusively, statistically showed us that we probably should not be doing primary stenting, and yet every single person who treats this disease does. The reason we do is because we were worried about the elastic recoil of the iliac segment. It tends to really spasm down very significantly when you just do angioplasty alone and really benefits from a stent scaffolding. Also, for really tight lesions, we worry about rupturing the vessel. Sometimes it's nice to have a stent there. We'll come back to that when we talk about covered stenting. If you look at the Kaplan-Meier curves from that Dutch trial, this looks at the whole group, showing really no statistically significant difference in patency. Trend, I know it says 0.03, but if you really trend it out longer, it has not been shown to have a significant difference in patency, unless you really subdivide out the really bad lesions. So there's this thing called TASC, which is the Transatlantic Societal Consensus, which is a poorly written document that goes over what different anatomic features are favorable for stenting and which ones are favorable for open bypass grafting. It was written in the early 2000s, is probably not relevant today, which is why I didn't want to go into it too much. But if you subdivide out what we call TASC C and D lesions, occluded blood vessels, in that case, primary stenting really did end up being a much better option than angioplasty with secondary stenting. And that's what most of us tend to do. The other thing that's come out is the idea of covered stenting. So I don't think there are any FDA-approved covered stents for the coronaries, if I remember correctly, but we tend to use stents that have a plastic or PTFE covering on them. Obviously, the most common reason to do that is in the treatment of abdominal aortic aneurysms. But there are balloon expandable ones, like this Atrium ICAS stent here, that is designed to be expanded inside the iliac segment and then exclude that thrombus and exclude that calcium. And obviously, if the vessel ruptures, then you've already treated that rupture because the blood is just going through the stent alone. This image demonstrates a technique that we call kissing iliac stents. If you hear about kissing stents, this is what we're talking about. The disease tends to involve the aortic bifurcation. It extends right up to where the aorta bifurcates. And it's hard to land a stent so that you can properly treat the aortic bifurcation without also compromising blood flow to the other leg. So what we'll often do is put stents from each side and raise the aortic bifurcation slightly. So we end up putting the aortic bifurcation slightly higher than it used to be. We don't like doing that. It's not a nice, elegant way to treat the disease because for the most part it causes significant alterations in the aortic blood flow, and it makes it difficult to get contralateral access up and over for when you have to treat the patient's disease on the other side. If you look at the ICAST trial for covered stent grafting, again, this is the total group showing maybe some mild benefit for the patients who underwent covered stent grafting. But in reality, when you take out the patients with task C and D lesions again, the occluded patients, there's a significant benefit probably to covered stent grafting. And that's changed how we've thought about this. So modern aortoiliac treatment really is more commonly done as a hybrid approach. The disease oftentimes extends into the groin vessels, where stents don't tend to work very well because of flexion points. And we'll often treat the groin with a common femoral endarterectomy, as depicted here in a black and white picture, and then do retrograde stenting through that endarterectomy site at the same time to treat the entire iliofemoral segment all at once. When we're stenting the iliofemoral segment, we're more and more commonly using aortic stent grafts. This is the Endologix aortic stent graft, which is a bifurcated piece which sits right on the bifurcation. That allows us to treat this without having to raise that bifurcation with kissing stents. Kissing stents tend to not really treat that aortic bifurcation very well. We think this is a better way to do it. This is a patient of ours who had some significant claudication of the right leg. The angiogram doesn't project very well on that screen, but you can see the abdominal aorta, and what you see is significant lumbar collateralizations. You sort of see the iliac here, and you see the wire coming up here. This is not the iliac, this is a collateral, and then we've put an Endologix in, coming back to treat this after we've taken this picture, but you can see how that really opens it up and makes it look like a native aorta. Honestly, the biggest problem we have with this treatment strategy right now is that there is no CPT code for the use of an aortic stent graft to fix occlusive disease, and you can't bill it as an aneurysm, so the hospital eats the cost. That's supposed to change this month when it's going ahead of CMS. Moving on to femoropopliteal disease. Obviously, femoropopliteal disease, SFA occlusions are the most common things that we see in all of atherosclerosis. The most commonly occluded blood vessel in your body is actually the SFA. A lot of that has to do with the fact that it's an extremely long vessel, but it tends to be very close to flexion points. A lot of people have SFA disease, some of which are symptomatic, some of which are not. However, there are significant barriers to how we can treat the SFA. There's often very long occlusive segments. It's near the knee, which is a flexion point, and it's often heavily calcified in the adductor hiatus. For the most part, traditional percutaneous therapies haven't done that well, angioplasty and bare metal stenting. This is a meta-analysis looking at outcomes after angioplasty or stenting for claudication, depending on whether there was an occlusion or not, and then for critical ischemia, if there was an occlusion or not. I know it doesn't look like it changes very much, but realize we're talking about a 60-year patency rate at 5 years for a very straightforward, non-occluded claudicant. You would never accept that in the coronary literature, right? For about the easiest case you can think of, a 60% 5-year patency, that's terrible, right? It's part of the reason that for a long time, femoropopliteal bypass grafting was a superior choice to endovascular therapy. However, there have been a lot of technological advancements over the last 15 years, and in most cases they were borrowed from PCI and now increasingly from neurointerventional. Atherectomy, many of you are familiar with, but again, the idea there is to debulk the calcium, allow an angioplasty balloon to work better in sort of an affected artery that's a little more compliant. We're going to talk about drug-eluting stents and drug-coated balloons a little bit as well, and then covered stenting. I'm not going to have a separate slide on it, but I want to talk about retrograde recanalization. This has really revolutionized how aggressive we're able to be in treating endovascular patients. So we'll access the posterior tibial artery at the ankle under ultrasound guidance, cross with a wire, and then snare that wire from above to allow us to treat the leg. For whatever reason, and we don't quite understand why, SFAs are easier to cross in a retrograde fashion. It probably has something to do with how the plaque sort of tunnels down, but they're much easier to cross in a retrograde fashion, and iliacs are much easier to cross in an antegrade fashion. None of us are sure why that's the case, but it's consistently shown in our literature over and over again. Touching on atherectomy, again, many of you have used these devices in either lower extremity or other vascular beds. Laser excimer atherectomy was kind of the first on the scene, but quite honestly is almost never used anymore. The three major atherectomy devices available in the United States are the Silverhawk, the Jetstream Pathway, and the Diamondback, which is stealth. All three are reasonable options with a variety of different pros and cons that I want to get into. This is data from the laser excimer group. Their initial atherectomy literature looking at angioplasty alone versus atherectomy with angioplasty, showing a mild improvement over a one-year period, looking at patency rates of the lesion. That's it in terms of comparative head-to-head trials looking at atherectomy versus angioplasty in the femoropopliteal segment. That's it. The only things we have are basically the trials that got these devices FDA approval. A single-arm study showing safety, showing efficacy, but no comparative literature, no randomized control trials really that have been worth anything. That hasn't stopped people from doing them, right? So from 2004, this is only showing 2-year data, but we've seen a dramatic increase in the amount of percutaneous atherectomy that was done. This increased for a while. I don't have data up until the current era, and then leveled off. What do you guys think was the main reason that it leveled off? Significant changes to the reimbursement profile, right? So atherectomy for a while had a major financial benefit associated with it, which we're not realizing now. It's still done, but it's probably not as done as routinely as previously. More encouraging has been the transition of drug therapy from the PCI world to the lower extremity. So the IMPACT trial looked at a paclitaxel-coated balloon versus angioplasty alone, primarily claudicants, but some patients with critical limb ischemia. This was multinational, multi-institutional, obviously, which demonstrated that for the most part, the drug-coated balloon did a really great job. You're looking at a 97% patency rate at 1 year. You're looking at a statistically significant improvement over angioplasty alone, and this data has led to an FDA-approved lower extremity balloon. It came out a year ago or so. The company that released it really had an aggressive financial request for centers that wanted to use the drug-coated balloon for lower extremity work. Thankfully, there's been a second balloon since then that's drug-coated and able to be used. So this is seeing a lot of increased use. There's a lot of interest in combining this with atherectomy, where you're debulking the vessel, delivering the drug how you want it delivered, and then hopefully getting some sort of long-term patency rate. Part of that is looking for a use for atherectomy, right, to justify its use, to justify the reimbursements for the cost. Thankfully, there's also now a FDA-approved drug-eluting stent. So again, paclitaxel-coated, this is a Quicksilver PTX. This was approved in 2012, had some significant problems with the rollout, and really didn't see widespread clinical use across the country until about 2014. But their data is relatively encouraging. This is drug-eluting stent versus bare metal for fempop disease. A lot of these were not occlusions, they were stenoses only. But again, statistically significant benefit in patency rates, freedom from TLRs, freedom from target lesion revascularization down the road. So even out to 4 years, showing that there was some benefit of the PTX. Last technological advance I want to talk about with stents. Just as we had atrium ICAS for covered balloon expandable stents, we have covered self-expanding stents. This is the Gore Viabon endoprosthesis, which many of you have seen before. A lot of different applications. We actually use it a lot in trauma for endovascular management of traumatic injury. And their ViaStar study looked at 141 patients that had either the Gore stent graft placed in an SFA or a bare metal stent. Their protocol deviation rate was about 8%, which is reasonably high. So they sort of have two different curves. One is the patency rates per protocol, and then by the intention for treat. The intention to treat didn't show any difference because they had, and most of us throw it out because they had so much crossover between the two groups. But if you look at the per protocol, there's some data that suggests that maybe it's a reasonable thing to do. Okay, so now I've confused the hell out of everyone because I've thrown up a bunch of stent data. The bottom line is we went in a very short period of time to having almost no reasonable interventions available for the SFA outside of angioplasty and really badly designed bare metal stents, to having a wealth of options, including atherectomy, drug-coated balloons, drug-eluting stents, covered stent grafts, and yet we still do not have comparative data between the different ways of treating the blood vessels. All of us have sort of come up with a hodgepodge of ways that we want to do it, many times combining these things, The new in vogue thing over the last year or so is to use a Viabond covered stent graft and then to line that Viabond with a drug-eluting stent at its distal and proximal ends to get drug delivery to prevent edge stenosis. It's a very expensive way to take care of these patients. It's not certainly shown to be efficacious in any sort of comparative data. We're waiting for it. And quite honestly, we're kind of excited because what we've seen also over the last 2-3 years or so is we've seen consolidation in industry. So every company wants to be the go-to standalone company that delivers every single one of these options. So we see the atherectomy company buying a drug-coated balloon. We see the covered stent graft company looking at different technologies that they can bring in to increase their portfolio. And that's going to allow the comparative studies, right? Because no one wants to do a comparative study against another company. But if you have it all in-house, then you can run that sort of thing, potentially. It hasn't stopped what we thought has been a pretty major growth. This is market value of everyone who does lower extremity device work. So this is a huge field that's seen pretty consistent growth over the last few years and is projected to see pretty consistent growth over the next 10. Most of this is not very well data driven. We do not have the luxury of thousands and thousand patient registries like we have in the PCI world. Most of this is very small, single arm stuff, very few comparative trials looking at different ways of treating these patients. All right. Those are the three things that I wanted to mainly touch on, again, keeping in mind what the outcomes that we're looking for. What's next? I think that further cell and gene therapy advancements, like we've discussed, is probably the biggest thing that we're going to see on the medical side. I think that one of the big things that's come out over the last 5 years is that our VQI database, which is a national registry, has allowed us to really make some big population-based queries into how we're treating patients. And one of the more sobering things that's come up is that if you take smokers who were claudicants and you left them alone, we said before that their amputation rate over 5 years is probably about 4%. If you start intervening on them, like we have for quality of life, that amputation rate is probably around 6 or 7% around 5 years. There is a significant quality of life improvement for the patients who don't lose their legs, but are we doing the right thing in trading off quality of life improvements for an increased risk of limb salvage, of limb loss? So we've sort of seen the pendulum probably swing a little bit too far the one way, where we're really starting to get aggressive with taking care of claudicants, and just now starting to swing the other way, where we're putting some thought back into really thinking about increased medical use, really coming away from treating the smokers as aggressively as we have as a field. And then I think seeing some of these comparative technology assessments, randomized trials looking at atherectomy versus angioplasty alone, drug-eluting stent versus atherectomy, et cetera, and combining different treatment modalities. I think that's pretty much it. Happy to take any questions.
Thanks, Ravi. That was great. I'll start off with a question about where you started at the beginning. I think I knew that most claudicants don't progress to critical limb ischemia, but I was a little surprised when you said that the CLI patients often don't have claudication histories prior. I guess is that real, or is that just underreporting of symptoms, or does that tell us a little bit more about the pathophysiology?
Some of that is for effect, right, to make the distinction between the two different disease processes. We're taught in general surgery that no one shows up with acute cholecystitis out of the blue, that every single patient with acute cholecystitis has some antecedent history of biliary colic. The point being that it's not necessarily the same for limb loss, for tissue loss. I can't tell you how many times I've seen a trainee present a tissue loss patient and say, but they don't have any antecedent claudication. Certainly it can happen, but for the most part, because the vascular beds are differently affected, it doesn't have to happen, is probably a better way of saying it. It's not a requirement to have tissue loss that you had antecedent claudication. In fact, it's probably slightly under 50% anecdotally.
Thanks. Very, very nice. The question I have, it relates to the growth of SFA intervention. It looks like it may be parallel to or even slightly less than the growth of the number of patients in the United States who are over 65. So is the growth per capita increasing, or is it staying the same, or is it going down?
It's both. I don't think I showed that in a slide specifically, but it's both. Certainly a lot of it is denominator driven, how many patients are we treating, but there's also an increased trend towards what percentage of patients are being treated percutaneously.
Ravi, very nice talk. So I think one of the problems has been the semantics. I think you started your talk very nicely by saying a disservice was done in medical school. Claudication, when that's defined, it's not found commonly in PAD. I mean, that's been shown in multiple trials. So I think when Bob is asking the question that is it present or not, I agree with you that claudication is not present, but the symptoms of PAD are present.
Yeah.
I mean, I normally don't ask for much claudication. I ask, are you walking slowly? And I ask the family members, have you noticed over the past few years that the patient can't keep up? They become more sedentary because the disease progresses so slowly. They alter their lifestyle. It's the same way like if we were going to only diagnose coronary artery disease by chest pain, not be cognizant of other symptoms of dyspnea and exertion or in diabetics who don't have chest pain, we'll be missing a whole lot of coronary artery disease. So I think the same thing has happened in the literature that till the other specialties became interested in peripheral vascular disease and they started looking into this thing. Though the partner study that was done early in 2000 clearly showed that less than 11% of patients with documented PAD, large vessel PAD, not dinky little vessels, they only 11% had claudication. And a large number were asymptomatic because they became, in my experience, I've found that in patients who present to me with critical limb ischemia, if I really ask them the question, they give me the history that they had peripheral arterial disease symptoms, but they just did not realize it, and the physicians did not ask them the questions. So they had become more sedentary. They developed diabetes, which develops more prone to multivessel disease, because if they may have proximal SFA disease, in diabetics, we tend to see more below the knee disease. So I personally think there's been a problem with semantics, and that's why literature is extremely confusing when they say, well, claudicants don't amputate. Well, you show me a lesion of 90% and leave it untreated, and I will show you an amputation a few years down the road.
Yeah, you're absolutely right. I mean, if you remember, in medical school, we used to say there are atypical symptoms of claudication, right? Leg heaviness, leg numbness, when in reality, that's probably the PAD. And part of it is this generational idea of defined outcome measures. So there's been a dramatic increase in interest in more the functional status of the patient, how quickly can you walk, how far can you walk after revascularization, as opposed to looking at binary outcome measures like limb loss or very objective measurements like pain-free walking distance.
Every time Dr. Niazi does a lower extremity revascularization, he tells the patient that in order to keep your leg open, you need to walk. Are there data as far as lifestyle changes? In other words, that we can tell patients, look, if you stop smoking, there's an X% chance that your leg will remain open. Or if you walk 30 minutes a day or 15 minutes a day, you have a greater chance of keeping your legs patent.
Yeah. So absolutely. So the good news is all of the things that we want our patients to do anyways are associated with increased patency rates of both percutaneous therapy and open bypass, right? So antiplatelet use, anti-lipid use, exercise programs, smoking cessation, and some series silastazole have been shown to increase patency rates of all of our interventions. So we absolutely can tell them, if you keep smoking, this is the expected outcome in X% of the patients. I have a harder time understanding who's going to quit smoking. Right? I have a harder time knowing who's going to take it seriously enough to quit smoking. I think you have to use some population-based series to say, listen, if we intervene on smokers, this is going to happen, and I think that's what CMS is going to do. Right? And say, listen, you can't do interventions on smokers because we are starting to see a really, really bad trend over the last 2 or 3 years towards increased limb loss rates in claudicants who continue to smoke when they probably would not have lost their leg except in certain cases before. But absolutely, we have very good data showing us what are the risk factors for restenosis, and thankfully it's most of the stuff that we want them to do anyways.
Ravi, it will be an interesting study to look at patients who we endovascular revascularize and split them into two groups, one who exercise and continue to smoke, and one who don't exercise and continue to smoke. Can exercise negate the detrimental effects of smoking that brings on restenosis? Because with technology improving, I think we'll impact even the smokers, their restenosis rates with the drug-coated balloons. Is that, and Because as Rob was mentioning, I push people to exercise. But just as you say, it's very hard to predict who's going to stop smoking. For me, it is much harder to predict who's going to exercise on a regular basis.
Absolutely.
That old dad, I'll walk a mile for a camel.
All right. Well, on that, I think we'll end it up. All right. Thanks a lot, Rob. Appreciate it. That's good.
The preceding program is copyrighted by Emory University.